Hi YouTube, so this is Candace with Counseling Minus the Fool. Today we're going to do disorder like I promised. Today I want to do bipolar disorder. Now this disorder is definitely I will say amongst common people, or I meant nothing by common people, but amongst people it is usually said very loosely. So this is another disorder that everyone kind of refers to very loosely. So in this sense, they're using it as mood swings characteristics. So they say you have somebody who may be easily irritated, or also just easy to be angered, or things of that nature. This is something that everyone will tend to use to try to categorize the individual. However, this is another disorder that I feel can be misinterpreted, is used too calmly, used too loosely. So what I want to do is kind of break it down better, for a better understanding, for awareness, and to kind of block out the ignorance of people just using it so loosely. So let's get a little educated today. We're going to talk about bipolar disorder. So I have my handy dandy cheat sheet. It's my binder, actually. I don't know if you can see it. I'm terrible at this. It's a binder that I have put together with bipolar disorders and some assessments and just some stuff I have in my internship. But that's what I did as a student with my graduate program. So anyway, this handy dandy binder and information is going to carry me through my career. So pretty much this order, I'm just going to read from the paper for this because, like I said, I want to be accurate, on point, and make sure that this is diagnosed correctly. So the core characteristics of bipolar disorder is extreme affective dysregulation, or a swinging of mood swings, mood states from extremely low to extremely high. So extremely low, let's say down here, to extremely high. Okay. Patience in manic episode, meaning, pretty much if you're in this if you're in a manic state, you're like you don't need any sleep. You're doing your impulse control is very you don't have any impulse control. So you don't have any self-control. You're spending. You may be acting out sexually. So just a lot of things that it looks like. So when you're currently in an episode, you want to say you can say manic. When you're currently in an episode, that's what manic looks like. So patients in a manic episode experience euphoria. You elevate mood, irritability, behavioral activation, alter cognition functioning, so the way you think. For a diagnosis of a manic episode, there must be evidence that the person's psychosocial functioning is disrupted. So like I said, with any of these disorders, you're looking for an impairment in your daily functioning. It may be in your daily life, in your personal life, in school, your work life, your relationships. Episodes of dysfunction mood often separated by periods of normal mood. So you have a baseline. Everyone has a baseline of how you tend to act, of your mental state. Even with the mental health disorder, you still have a baseline of what that sense of normal looks like for you. And it's classified to either bipolar 1 or bipolar 2. Bipolar 2, it differs from bipolar 1 disorder primarily in its lack of any manic episodes. So bipolar 2 includes at least one of the hypomanic episodes and at least one depressive episode, but lacks the full-blown manic episode that is bipolar 1. And also, like I said, you have to have a depressive episode. So you're looking at bipolar 1, you needing to have MDD, which we did a video about major depressive disorder. So bipolar disorder tends to begin at times of high stress. when you're stressed out. Individuals with BPD, which is bipolar disorder, are more independent and dominant. They are less guilty and anxious and prone to instability. BPD, long-term illness, is a variable course. The first episode of BPD may be manic, may be mixed, may be depressive, may be followed by several years, which the patient is symptom-free. The illness may be associated with substance abuse, recklessness, impulsivity, truancy, antisocial behavior. That will be a good one. I think we can do that mental health disorder next. That would be a good one. Antisocial behavior. It's also associated with diagnosis of bipolar disorder. It must be carefully differentiated from substance abuse related or antisocial behavior or personality disorders. So some of the criteria, let's go into it, is it's associated with less anger, oversleeping and psychomotor retardation, anxiety, psychotic thinking, and it's worse in the morning. And I'm trying to pronounce this word correctly. It just never comes out right. So I'm just really hesitating to say it. Somatizing. So, okay. I hope you get my drift. So the manic episode is an elevated, expansive mood that lasts 1 week with at least three of these following things. So decreased need for sleep. Oh my God. When I'm at work and I work at this hospital and I work on the psych floor, definitely. I know it's definitely manic because some of the patients are up for 3 days in a row and no sleep at all and doesn't bother them. And then sometimes they get something to help them sleep and it just does nothing for them. So that's how you know full-blown manic episode. Increased talkativeness, racing thoughts, distractibility, increased activity, excessive pleasure seeking, so that can be shopping, gambling, sexual acting out, grandiosity. And then so I'm just reading some potential risk factors. I want to see if I want to go there. We already talked about high levels of stress being one. So with BPD is actually categorized as a mood disorder, and we've kind of talked about some of the treatments for mood disorders. So I would just go back. Oh, actually, no, I take that back. So this categories under wow. Yeah, I'm surprised. Okay. All right. So anyway, so some of the treatment, let's go. I just really was gonna go to this one page and go from there, but it actually breaks it down a little better. So I'm just gonna use this information. So the treatment is very important for a counselor, for a therapist to establish a rapport with the client. So to establish a professional relationship, because with bipolar disorder, as my professor stated, it's either you're all good with people or you're all bad. So you see people as all good or all bad. And once they become all bad, there is a disconnection. There is a elimination in the relationship. So people with bipolar disorder usually get terminated or leave jobs very frequently. Relationships is very very limited, I should say, because I see you as all good, and then when something happens and you disappoint me, I see you as all bad. So that's the end of the relationship. So those are some signs as well. So forming that relationship is very crucial. You monitoring medication, because bipolar disorder, a lot of the people who have this disorder are not medically compliant, so they're not taking their medication as needed. So just making sure that you are monitoring the medication and making sure they are being compliant, charting the moods, educating them about the disorder, developing a treatment plan. So with this treatment plan, what does that look like? Let's see. I'm just making sure I didn't. I really try to do this briefly, so I'm just making sure I didn't leave anything out. So we talked a lot about cognitive behavior therapy. So let's just start there. There's other forms of intervention as far as treatment plan, but with CBT, you want to look at it emphasizes education about BPD and its management, as well as cognitive restructuring, problem solving, and routine and sleep management interventions. So we can do like psychoeducation, so educating about the disorder, cognitive restructuring, that's transforming the way you think, assertiveness, so you're training yourself to be assertive. Problem solving, like I said, is either all good, all bad, elimination. Activity management and medication adherence. Treatment has demonstrated effectiveness in significantly reducing the number of new episodes and increasing your orthotic periods relative to medication alone comparison. This is a lot of stuff that kind of will bore you, so I'm trying to get through it and be entertained at the same time. Feelings of behavior, attention is placed on use of vivid members. Okay, it's started to crystallize important. Yeah, it's just telling you what to do in individual sessions when you're trying to build a rapport with a client with this disorder. So other things that you can do is marital and family therapy. So you want to educate the person's spouse, educate the family about what the person may be going through with this disorder. It's also just good so you can kind of know what to expect and what to kind of how to help in these situations. Yes, and then there's also another model in here. It's comprehensive rehabilitation model of treatment. It is empathetic and positive treatment, education about the disorder, plotting the course of the disorder, symptom management, improvement of lifestyle and the environment, assessment of the client's function and development, and assessment of the client's coping skills and support. One thing I would just throw in there, just individualize, definitely working on coping skills, also homework assignments. I would throw in maybe some deep breathing and things of that nature, because like I said, it's either all good, all bad. So you kind of want to just work with them about just showing that people will let you down, people will disappoint you. However, people are not always seen as all good, all bad. There is a such thing called seeing white and black, but sometimes things are in the gray area. So just kind of working with them to see that everything isn't so point blank and period. It's just my own thing I would throw in there with working with someone who have bipolar disorder. I'm going to stop here because we're going to approach 15 minutes. So this video, I hope if it taught you anything, it's just some type of awareness and some type of distinction between really being jokingly about the disorder, which I feel like joking about this disorder, any disorder, is never funny, because when you're battling a mental health disorder, It's just ignorance to joke about it, because it affects such everyday basis and functioning, and really just affects every part of a person's life. So I just hope and I challenge you not to use the disorder so loosely, and also that you did learn what it really means to have the disorder, and some of the things that, some of the characteristics and some of the things that you can kind of see to really get an understanding. So for me, I worked with someone who disclosed that they were bipolar, and bipolar disorder 1, I will say, because she disclosed to me that she would have really high moments where she's, manic, no sleeping, shopping, gambling, sexually acting out, and then having really low moments where she's not answering the phone calls, she's not being receptive to her husband, she's having suicidal thoughts. So this disorder is really, really more serious than what a lot of people kind of joke about. And then just me being in school and just being able to identify each mood and the mood swings, where the in-between kind of would be just her normal baseline of her being just sociable, and then kind of noticing her mood dwindling to the point where she's quiet. She's quiet. It's days that she would come into work and would say nothing. So, just recognizing her baseline and herself and her state of mind, that's the biggest thing. And for me, not always pointing out like, hey, what's going on with you? What's wrong? Like, what I'm saying? People share what they want to share. And being non-judgmental, building that rapport is something that I did when I did recognize, and she disclosed to me that she battled this disorder, and we really got along. Really get along. So I wouldn't say that the prognosis, which means I wouldn't say that the outcome is not successful. I would push for medication compliance and coping skills, and that relationship to really be a factor in educating the individual to really be assets to treatment. So I'll end it here. Thanks for watching. I'll see you next time. I'm going to claim that we're going to do antisocial personality next time. But you know how things go. Sometimes I'm just motivated by how what I'm going through, or I'm motivated by something that I'm seeing that's going on. So we'll see. Thanks for watching. Let's continue on this journey together with growth, healing, and loving. And I'll see you next time with Counseling Minus the Bore.